This video describes the KTEA Dyslexia Index and how it is used as part of dyslexia screening. The materials in this video include KTEA-3 information. The information is protected by federal and international copyright laws. Pearson grants the qualified KTEA-3 user permission to access the materials for his or her sole use. The materials are not for use by any non-authorized user or for any other distribution. This brief presentation will define dyslexia, discuss the importance of screening for dyslexia, describe characteristics of an effective screening test, and describe features of the KTEA-3 Dyslexia Index as it is used for dyslexia screening. The word dyslexia is derived from the Greek word dys, meaning poor or inadequate, and the word lexis, meaning words or language. Conceptually, dyslexia is a learning disorder characterized by problems in processing words into meaningful information. In 2002, the Board of Directors of the International Dyslexia Association described dyslexia as a specific learning disability that is neurological in origin. The individual may struggle to name words fluently and accurately. Spelling is usually poor, and the individual may struggle to use strategies to decode words. Difficulties with word recognition, spelling, and decoding typically result from a deficit in the phonological component of language and are often unexpected in relation to other cognitive abilities and the provision of effective classroom instruction. These difficulties can impact reading comprehension and reading experience, which in turn impede growth of vocabulary and background knowledge. In 2015, the U.S. Senate voted unanimously as part of the Cassidy-Mikulski Senate Resolution 275 to establish the following definition of dyslexia: an unexpected difficulty in reading for an individual who has the intelligence to be a much better reader, most commonly caused by a difficulty in the phonological processing, the appreciation of the individual's sounds or spoken language, which affects the ability of an individual to speak, read, and spell. This definition is captured in the First Step Act, a bill signed into law in 2018. There are several reasons to screen for dyslexia as early as possible. First, dyslexia is common. According to an FAQ document from the Yale Center for Dyslexia and Creativity, dyslexia affects 20% of the population and represents 80 to 90% of those with learning disabilities. It is the most common of all neurocognitive disorders. Second, it is important to screen for dyslexia early because the achievement gap between typical readers and readers with dyslexia is already present as early as first grade. Even more, as you can see from the image on the right of the screen, dyslexia persists and impacts students over time. Early screening combined with high-quality, evidence-based interventions are essential for closing this achievement gap. Screening tests are brief measures that are intended to sort individuals into two groups: those at risk and those not at risk. Screening tests are evaluated based on several characteristics. First, screening tests should be evidence-based. The use of a screener should be supported by sound scientific evidence, including strong reliability and validity data. Second, screening tests should be reliable. The screener's reliability coefficients should provide evidence that the items are internally consistent. Information should be provided to determine whether the results are stable over time and across scores or raters. Third, screening tests should be valid. The screening test should measure what it claims to measure. The most important type of validity evidence for a dyslexia screener is clinical validity. The clinical validity of a screening test is evaluated based on its sensitivity, specificity, and area under the receiver operating characteristics curve. The sensitivity of a dyslexia screening test refers to its strength in finding true positives, that is, individuals who have dyslexia. The specificity refers to its strength in eliminating true negatives, that is, individuals who do not have dyslexia. AUC estimates range from 0.50 chance accuracy to 1.0 perfect accuracy. If you use the KTEA-3, you know that the instrument includes two forms, A and B. Here's the image from the Dyslexia Index Record Form, Form A. As you can see from this image, 6 KTEA subtests contribute to the Dyslexia Index. The KTEA-3 Dyslexia Index for grades kindergarten and 1 includes the phonological processing, letter and word recognition, and letter naming facility subtest, which are designed to measure phonological processing, letter knowledge, phonics, letter sound correspondence, word reading, and rapid automatic naming skills. The KTEA-3 Dyslexia Index for grades 2 and higher includes the nonsense word decoding, spelling, and word recognition fluency subtest, which are designed to measure phonic decoding, spelling, and word reading fluency skills. The subtests for the Dyslexia Index are individually administered. Administration is typically less than 20 minutes for examinees in kindergarten and first grade, and less than 15 minutes for students in grades 2 and higher. Here's the same information for Form B. The print materials needed to administer the subtests for the Dyslexia Index include the Dyslexia Index Manual, Dyslexia Index Record Form, Form A or Form B, and the Dyslexia Index Response Booklet, Form A or Form B. To present the subtest, examiners need the audio files, which provide examples of how to administer or score several subtests. Examiners also need the administration directions for the Dyslexia Index subtest and the Dyslexia Index Stimulus Book, which are available in digital format for Form A and B. Examiners must apply several materials, including a stopwatch to use for precise timing on the letter naming facility and word recognition fluency subtests. A handheld stopwatch or a stopwatch app on a smartphone or computer can be used. An audio recording device is strongly recommended for administering the phonological processing, letter and word recognition, nonsense word decoding, letter naming facility, and word recognition fluency subtests, which require verbatim recording of oral responses. For examiners who already own the KTEA comprehensive form, fewer testing materials are required for administration. The Dyslexia Index subtests can be administered using the KTEA-3 comprehensive form stimulus books, along with the record form and response booklet from either the Dyslexia Index or the KTEA-3 comprehensive form. In addition to the items for each of the 6 subtests, the Dyslexia Index record form includes a section for you to document risk factors for dyslexia and exclusionary factors. Risk factors include a family history of dyslexia, difficulty acquiring early reading skills, and a history of language delay or language disorder. The record form also includes a section to provide information on exclusionary factors. There are a number of potential explanations for academic difficulty other than dyslexia that must be considered before making a diagnosis of dyslexia. Considering these factors is also critically important for helping individuals without dyslexia who are struggling academically. Some of these factors, such as diagnoses of language or attention disorders, may be comorbid and do not necessarily rule out a diagnosis of dyslexia. However, this information is helpful to inform a differential diagnosis as part of an in-depth subsequent evaluation. The KTEA-3 Dyslexia Index can be hand-scored using the Dyslexia Index record form and the norms tables included in the Dyslexia Index manual. Here's an example of a completed form. Following the administration of each subtest and calculating the raw score, the examiner transferred the raw scores from inside the record form to the Dyslexia Index computation form on page 2 of the record form. As pictured here, a student in grade 1 earned the following subtest raw scores: 19 for phonological processing, 21 for letter and word recognition, and 4 for letter naming facility. Using grade norms for the fall administration, the examiner entered table B.1 and identified the standard score for each of the 3 subtests: 84 for phonological processing, 81 for letter and word recognition, and 64 for letter naming facility. The examiner then calculated the sum of standard scores, which is 229. Finally, the examiner used table B.2 to identify the dyslexia index based on the sum of standard scores. Note the dyslexia index is 67 for the grade 1 student. To facilitate score interpretation, a risk classification scale is provided on the Dyslexia Index record form. As you can see here, 6 categories of risk for dyslexia are provided, and each one is defined by a standard score range. At the extremes, standard scores of 98 and above are considered to be at very low risk for dyslexia, and standard scores between 90 and 97 are considered to be at low risk for dyslexia. Standard scores below 70 are considered to be at very high risk for dyslexia, and standard scores between 70 and 76 are considered to be at high risk for dyslexia. The Dyslexia Index of 67 for the sample first grade student indicates his risk for dyslexia is very high. These results on their own are not sufficient to identify or diagnose dyslexia, so a comprehensive evaluation is recommended. The subtest and composite reliabilities by age are very similar in level and pattern to those for the corresponding grades. The average internal consistency reliability coefficients are presented here for the grade-based normative sample and for the age-based normative sample. Reliabilities for the KTEA-3 Dyslexia Index are excellent at every grade level and age, with reliabilities trending slightly higher for the Dyslexia Index for grades 2 and higher relative to the Dyslexia Index for kindergarten and first grade. The industry standard criterion for evaluating the quality of a screening measure is the area under the curve estimate, or the AUC estimate. This is the area under the receiver operating characteristic curve, the ROC curve. AUC estimates range from 0.50 chance accuracy to 1.0 perfect accuracy. Traditional benchmarks suggest that values equal to or greater than 0.9 are excellent. Values equal to or greater than 0.8 are good. Values equal to or greater than 0.7 are fair, and values less than 0.7 are poor. However, many of the strongest performing clinical assessment inventories deliver AUC estimates in the 0.7 to 0.8 range because of imperfect diagnostic criteria. See Youngstrom, 2014. As shown in Table 4.16 in the KTEA-3 Dyslexia Index Manual, the AUC estimates for the Dyslexia Index scores indicate that both scores have very good to excellent accuracy in differentiating students with dyslexia from those without dyslexia. In summary, The KTEA-3 Dyslexia Index is ideal for dyslexia screening because it provides a clinically sensitive score with a brief administration time. The Dyslexia Index is useful in estimating risk for dyslexia among students in grades kindergarten and higher. To be considered a valid dyslexia screener, a test must provide evidence that the results differentiate between individuals with and without dyslexia. The KTEA-3 Dyslexia Index does this. Dyslexia screening is a process that must incorporate multiple sources of information in addition to clinical assessment data, such as curriculum-based measures, family, personal history, and input from parents, caregivers, and teachers. You should interpret the Dyslexia Index results alongside these other relevant sources of information to obtain a valid, reliable indication of an examinee's level of risk for dyslexia. Depending on the level of risk and the number and severity of risk indicators, the results can help determine which examinees require more frequent progress monitoring, more intensive instruction or intervention, or an in-depth psychoeducational evaluation. Thanks for viewing this brief video on the KTEA-3 Dyslexia Index. We hope you find the information useful for your work. If you have questions, email gloria.mchugh@pearson.com.